Today we are joined by Lars Blønd, a world-leading specialist in patella instability. Lars has done groundbreaking research. He wrote chapters and played a key role in the European Organization for Patella Instability. He's also the author of the only book in the world on the trochlear dysplasia, which is a condition where the groove for the kneecap is too flat. And this is a crucial piece of the puzzle in understanding patella instability, a very complex problem. So we'll be diving today into our conversation with Lars, and I hope many of you will have a chance to understand the complexity of patella instability or maybe how easy it is. So for many years, Lars split his time between a university hospital in Denmark and a private hospital. These days, he focuses entirely on his work at Aleris Private Hospital. He also shares a wealth of the patient-friendly resources on his own website, all dedicated to understanding and treating patella instability. So I encourage everyone to have a look at these resources. So Lars, would you like to say a few words and introduce yourself? Is there anything else that I missed in this information?
No, I think that was a great introduction, and thank you very much, Konrad, for inviting me for this, and hopefully the patient can get some clue about this very complex topic about patella instability, a problem that we have, I would say, somehow ignored for quite some years, and the past 10, 20 years, we've got so much new knowledge, and hopefully after having heard this, you will be better to help yourself with your knee problem.
Yes, Lars, maybe I missed one more very important thing. You have been also a great inspiration for me, for my clinical work. You help actually many of my patients, because for some time we collaborated together. I visited you in Denmark, and then you visited me in my hospital, and you helped me to operate on several of my patients, because you have developed this unique technique, which is trochleoplasty, that is done arthroscopically. So thanks to you, I had a chance to learn this technique from you, and then it became a very powerful tool in my handbag of the procedures that I use for patellar instability. Also, I'd like to mention that you visited the Congress I'm organizing for more than 10 years, the Joint Preservation Congress in Warsaw, where you've been visiting us so many times and sharing your valuable experience and showing the procedures that you do for treating the patella instability. So I'd like to take this opportunity to thank you so much for all your inspiration for me. But let's move to our conversation. Maybe we should start with just a simple question. What is exactly patella instability? How can you explain this problem?
Yeah. First of all, we have to understand the patella. That's the kneecap, and what can happen is that the kneecap pops out and goes out to the outer side of the knee, and this is a patella dislocation. It's not always that it pops all the way out. Sometimes it pops only out to the border and then it goes back. That's what we call patella subluxation. So either it's patella dislocation or it's patella subluxation.
So this is all based on the patient's anatomy, right? So why is it some people develop this problem but others don't?
Yeah, that's a very good question. First of all, it has something to do with the anatomy. How is the patient's knee built? And there can be some genetic involved, I mean heretic. And then naturally the activity of what did you do when when the patella pops out, sometimes you are doing quite heavy activity like soccer, handball, whatever contact sport, and sometimes you just make a small change in your direction while walking and the patella pops out. So there are many reasons for the patella pops out, but most cases there are some bony abnormality involved, meaning that the knee has for some reason not a perfect configuration.
So as I understood, and I think that it's important for the patients that they can understand that there has to be a special reason. There has to be a special type of the anatomy of the knee for the patella to dislocate, right?
Yeah, that's right. And many patients think that they have done something stupid, and that's the reason why the patella goes out. But it's just something that happens due to the way they're built, and it's not that they have made any incorrect movement or things like that.
So I think maybe we could, maybe you could explain to our patients how would someone know if they have an unstable kneecap, even if it hasn't dislocated again.
Yeah, I mean, first time people experience a real patellar dislocation where it sits outside, it's very traumatic and dramatic. Often there's a lot of pain involved, and it's a huge shock to the patient. And then the thing is that if this has occurred, then the patella tends to become unstable. And the way you feel this as a patient is that often it's just like if you make some special movement, you make some turns, you feel that the kneecaps is nearly going out, and yeah, then you get fear of using your knee, and there can also be pain involved, but. And then sometimes the patient just feels that their knee slips and they fall. That is not due to the patella has dislocated, but due to the patella has subluxated. And if the patella dislocate again, the patient is never in doubt that this has occurred, because that is quite uncomfortable.
Lars, so just to clarify the things, because I think that every orthopedic surgeon understands what's the difference between dislocation and subluxation of the patella. But maybe you could explain to some of people that might listen to this podcast who are not professionals, what's the difference?
Yeah, the difference is that when it subluxates, it nearly goes out. It goes to the border, and it feels very uncomfortable, and then it pops back. It's like maybe you can explain it like if you're in a bobsled going downhill, and you go out on the border, and you nearly feel that now this is the end, and you are going to pop out completely, but then suddenly it goes back. That is a subluxation. A dislocation is when it completely pops out.
Mm-hmm. So let's say that this problem is problem that is the problem of the anatomy. So this means that we were born with the knees like this. It's not the patient's fault. It's not the injury. It's not any other disease. So what is the usual timeline? How does it happen? Is it the problem of the very, very young patients, like 5-6 years old, or is it the problem of teenagers, or does it come in an adult life?
I mean, it's not so common when you are 5-6 years old, but it can occur. Mostly this occurs when you reach teenage, meaning from 10 to 17, 18 years. In this age group, there's a lot of patients who have their first-time patella dislocation. When you get older, meaning after 18 years, it's not so common that it goes out. But some patients experience their first dislocation when they are 30 years old, but it's not so common.
So what should I do if my kneecap dislocates? What's the immediate next step for me to do?
I mean, the first thing you should try to do is to straighten the knee, because normally that helps you to let the patella pops back into the groove where the patella tracks. And then you should go to emergency department to have an examination and X-ray, and you should have the correct treatment and evaluation, and then you should contact your insurance company and such things, and then you should go to a physiotherapist to train your knee.
So is it common in life to have only one dislocation, or let's say if I had dislocation, will it happen again?
Yeah, that's a difficult question to ask, because about 25 to 30% will experience a new dislocation. However, a large group of patients will experience these subluxation, and it can be just as troublesome as having a dislocation. So I would say about 50 to 60% of patients who have had a first-time patella dislocation will continue to have some persistent kind of patella instability.
So what is, because you were for many years a member of the organization, international organization for the surgeons to give recommendations on a treatment. So we know that some surgeons say that you should never operate after just only one dislocation, that it's better to wait and see what's going to happen next. So is that the correct approach? Would you recommend this?
I mean, since I started out dealing with this problem, and that's more than 25 years ago, it was a general rule that you should never operate what we call a first-time patella dislocation. However, since we have got new studies on this and we know more, we have realized that in some cases we need to do surgery, or at least talk to the patient, examine the patient, and find out what are the risks for the new dislocation, what are the symptoms after having had physiotherapy, and if patient continue have instability despite the patella do not dislocate, but if they have instability and it affects their quality of life, they need surgery, and they need the surgery to come back to recreational activities, sporting activities, and to prevent patella dislocation, and to prevent osteochondral lesion that occurs or can occur with a patella dislocation. So for many years, we have waited too long to operate some patient, because they came back in the age of 22, 25 with cartilage lesion in the knee that could have been prevented by having surgery early on. So the concept has changed during the past years.
So let's say I had the dislocation and I'm going to see a doctor or maybe physiotherapist after this dislocation. So what should I expect that's going to happen during this examination? What are the things that I should be aware of during this examination?
I mean, first of all, the one who's going to see you, the surgeon, the physiotherapist, they're gonna listen to what has happened, what are your symptoms, and then they should do a thorough examination of you, and they should also do at least an MRI scan. So that's very important. And after having done all this, and you have been to physiotherapy, and you come back to see how is everything going, then you shall find out what are your risk for further dislocation, what are your symptoms, can you avoid surgery, or should we recommend surgery? Yeah, so that is what you can expect.
Mm-hmm. So, can you, as a physician, when you examine someone's knee, what kind of signs, what kind of things that you can see during the examination?
I mean, first of all, you have to look at the knees. How is we call it aligned. That means how do they look? Have they, for example, what we call kissing knees, that the knees are pointed, the kneecaps are pointing inwards, or have been squinching patella? That you can see just by looking. And then you have to undergo an examination, both when you are lying supine, that means when your nose is up, and then when you're lying prone, meaning that when you lie on your stomach, and then you shall do different kind of examination to see how is your legs aligned, and how unstable is the patella, and in which position is the patella unstable. And then you should be sitting and straighten your knee, and you're gonna straighten the knee from bending to straight, and then you see how does the patella track, because you can have something called J sign. And if you have a J sign, it's a very bad sign, because that means something severe is ongoing for your kneecap.
Mm-hmm. So, what is the J sign? Can you explain to the patients what does it mean?
Yeah, the J sign is when you have your knee bended and you straighten it, then the patella, you can look at your patella, and it goes into the groove. But when you reach full extension, then the patella goes outwards, meaning that it suddenly turns outwards, and it can be just a small thing, but it can also be what we call a jumping J sign, where it really goes out to the outer side quite dramatically.
So, can you explain, because there are different types of instability. So for some patients, the patella would dislocate in extension, and for some, for example, would dislocate in flexion. So can you explain a little bit on this? What is the reason for this different types of dislocations?
I mean, most dislocation occurs in the start of flexion. I mean, in the start when you bend your knee from 0 to 30 degrees of flexion. In more rare cases, it occurs when the knee is flexed. And if it occurs when the knee is flexed, it's a quite complex thing. And then you should have then you should undergo surgery with some special surgeries, and I think that is too complex to talk about here. But yeah.
Well, there's one thing about the patella instability, that it is very, very complex problem, and it requires a very good understanding from the orthopedics or physiotherapists of what are the possible causes of instability. We know that there are many reasons for the instability of the patella. Alignment is important, rotation, position of the patella, the shape of the groove. So let's say I had a dislocation and I visited you, you tested my knee. So what are the next steps for you to what kind of imaging tools that you will use to understand what kind of instability do I have?
I mean, normally I always have an X-ray, and the X-ray can show some kind of give some signs that something severe is ongoing here. First of all, it can see if you have an osteochondral fracture, because if you have that, you need to undergo surgery very soon. Then you can see the thing about the groove. We call it trochlear dysplasia, meaning a flat groove. But you can also get a sign of if there is a torsional problem. We call it winking sign. But the most important is the MRI scan, because MRI scan, then you can see cartilage, you can see ligaments, and you can see bony abnormalities. So the MRI is the one where you will notice, for example, if there is trochlear dysplasia, or if there is patella alta. Patella alta is a high sitting patella or high riding patella. If you think there is some torsional problem involved in this, you have to do a CT scan as well to measure. This is a CT scan of both the hips, knees, and ankles to see if there is this torsional problem.
Mm-hmm. So maybe let's talk now about the treatment. We've discussed the examination, the imaging studies. So is, for example, physiotherapy enough for most of our patients?
Yeah, that's a good question. I mean, scientifically, physiotherapy has never been proven that it helps. However, I always recommend physiotherapy to strengthen the muscle, to help with the balancing and tracking. But in many cases, physiotherapy is not enough. And then if the patient still feel unstable, then you need surgery.
Mm-hmm. So how about the braces? Can we use the braces to stabilize the patella?
I mean, braces can be quite useful for some patients. Some patients say that they can feel that it helps them with the stability, but often it's the patient gets tired of the brace, and then they will go for surgery. But some patients who use a brace think that it doesn't help. In the acute phase, we used to use braces for all patients, but scientific studies has shown that do not really prevent further instability. So it's more in the chronic setting that you can use a patella brace that stabilizes the patella if you want to avoid surgery.
Mm-hmm. So let's say I'm the patient and I had the dislocation. I've tried brace. I tried physiotherapy, but it doesn't work. My patella still feels unstable. So what are the next options for me?
Yeah, first of all, it's very important to find out, why did the patella dislocate? Is there some bony abnormalities ongoing here? Because if you want to treat this patella dislocation with some kind of surgery, you need to find out how severe are those bony abnormalities. If there's no bony abnormalities, it's pretty simple to do what we call an MPFL reconstruction. That is a reconstruction of the ligament on the inner side of the patella. And this is, you can say, the MPFL reconstruction is the working horse for patella instability. I would say all or nearly all patella instabilities should be treated with an MPFL reconstruction. And then you can consider to do to correct these bony abnormalities concomitantly.
Mm-hmm. So just to explain our patients, MPFL, it's a shortcut from medial patellofemoral ligament. So this is the ligament that stabilizes patella on the medial side.
Yeah.
Just to clarify to our patients, is it the only ligament that stabilizes the patella? What are other ligaments?
Yeah, there are also, for example, the medial patella-tibial ligament. I don't find it so important, but it is there, and it has some but minor importance, I would say.
Mm-hmm. And just to explain, because I think that I hope that it is abandoned technique for for most of the surgeons to do the lateral release on the case of the patella instability. But I think, Lars, I still see sometimes patients coming to me which they had the patella dislocation and then they had done lateral release. Maybe you could briefly comment on this technique.
Yeah, I mean, it used to be a quite common procedure, but it turned out that it only makes things worse. That the lateral ligament also contribute to the patella stability, and when you cut it, you can make things worse. So after these studies came out, it has been somehow abandoned for the use when you do patella stabilizing surgery. It still has to, it still has a place in some rare cases, I would say, but I very rarely do this procedure.
Mm-hmm. So let's jump back to the MPFL reconstruction, medial patellofemoral ligament reconstruction. Can you explain to the audience how big of a surgery is MPFL reconstruction? How long does it take to recover and return to sports?
I mean, it is not a major surgery. It's a smaller surgery, and you can have full weight bearing after your surgery. You can have full range of movement. You don't need any brace. It's a one-day surgery, and the recovery time is a few months before you are back into sport. Normally, we say 4 months before you're back to contact sport. However, lighter sports you can start within, I would say, 3-4 weeks. So yeah.
Mm-hmm. So let's say, for example, my surgeon told me that MPFL is not an option or is not enough to do, and he's told me something about the location of the kneecap, that it's outside, and I need to have a tibial tubercle osteotomy. What is this? Can you explain to the people what is a tibial tubercle osteotomy?
Yeah, the tibial tubercle, that is the place where the ligament for the patella attach on the tibia. And if you, the patella is actually a bone inside the tendon of the ligamentum patella going from the quadriceps muscle down to the attachment to the tibia. And for many years, and still is a very common surgery is to do a medialization of the tibial tubercle. That means that you release the bone where the ligament attached, and then you move it more to the inner side. However, this surgery called its abbreviation is MTTO, and it has you have found out that it's an unnecessary surgery. There's no really difference between doing this or not doing this. So I have actually stopped doing this. I only do it in some very rare cases where there is a special condition where the knee is torn and you cannot do anything else by moving this to the inner side. However, there is also another tibial-tubercular osteotomy, and that's the distalization tibial osteotomy, meaning that if your patella is sitting too high, you can deattach the tibial tubercle and bring it more down. So you pull the patella down into the groove for the patella so it engages better, and that's a quite common surgery. It also helps to prevent osteoarthritis in the knee. So and it can also be important for reducing pain in the knee. So that's a very important surgery.
So the attachment of the patella on the tibia can be understood as a kind of like a joystick, so that we can move it distal or medial to change the location of the patella, and that's very powerful. That's very powerful osteotomy. Do you think, because in my practice, I sometimes use this technique to offload the patella also. So in some patients, I move it more anterior. Let's say I have patients who have a cartilage defect on the distal part, on the lower part of the patella, and by this we can slightly elevate this. Do you also think that this technique could be used to treat the patients with, let's say, isolated osteoarthritis of the patellofemoral joint?
I mean, I used to do many of these surgery, but the past years I have found that the results hasn't been as good as they should be. So now I do often other type of surgery. So I don't do many of these anymore. But yeah, for some it definitely helps.
So let's say we have a different scenario, and my surgeon told me that my groove, the kneecap groove on the femur, is too shallow, and other procedures will not work, and he has to done something like reshaping. Is that true? Is this happen? And what is the name of how do we call this surgery?
Yeah, first of all, the condition of having a flat trochlear is a condition named trochlear dysplasia. It's a very difficult name. And the surgery for this is the surgery where you deepen the groove to somehow help the patella to track better and to provide some also stability to the patella. And this surgery is called trochleoplasty. And for many years, this was a very rare and difficult surgery, but the past 20 years, it has been more and more common, at least in Europe. It's not very common in the United States yet, but also there it's becoming more and more common.
I think, Lars, that this is very powerful procedure. I think that since I started to use this technique in my clinical practice many years ago, it significantly changed the results of my surgeries. But I still see sometimes patients who have a trochlear dysplasia, which means that the groove is not even. It's just like a hill. So what would happen if I have this kind of groove, that there is no, it's there's no way that the patella can sit inside, but it's like a hill that patella can fall down. What if someone would do only MPFL reconstruction? If they would just do a ligament and they would say, no, this is fine, we just need to do an MPFL. What can be a result of this kind of surgery?
I mean, sometimes this surgery can be quite okay. But in many cases, it will not be okay, and the patient will have pain, or they will have a new dislocation since the forces to the patella is too high. So the ligament, the MPFL ligament, it re-ruptures. And Simon Donald, a professor on this, he said that it's difficult to balance a tennis ball on a football, and it's difficult to balance a patella on a hill, and therefore you need to do the trochleoplasty.
Mhm. Yeah, I think I asked this on purpose because I've seen a couple of patients that had done the MPFL reconstruction in a situation like this, and the result was that okay, they would say my knee is stable, but then they started to develop a different symptoms, which were the symptoms of the cartilage defect.
Yeah.
And you could clearly see on MRI of those patients before the surgery and after surgery that when the patella was kind of forced down to sit on the, like you said, like a tennis ball sitting on a football, that it just created a big damage to the cartilage. So we changed the instability into osteoarthritis, which doesn't seem logic, right?
That's correct, and I commonly see these problems, and I also do these patellofemoral prostheses, and we know that for those who are having a patellofemoral prosthesis, they're having it because they have osteoarthritis and pain, and that is in 75% of the cases, it's due to the condition trochlear dysplasia.
Mm-hmm. Yeah, I think that we should also highlight this, that usually this kind of problems, they are not the problems of patients in the 6th or 7th decade of their life. These are the problems of patients who are sometimes 20, 30 years old. And that's the tragedy, because we have to treat them like osteoarthritic patients, but they are too young to have a knee replacement.
Yeah, that's right. I recently had a patient. She was 30 years old. She had pain since she was 14, and severe pain, and she was not able to work. And when she was 30, she had so severe osteoarthritis that she had to have a patellofemoral prosthesis. And I think that could have avoided if she had a trochleoplasty in the early age.
Yes. So I think, Lars, we are coming to the most important part of this conversation, because you are a world renowned expert on the patella instability. But what you are probably most famous for is that you have developed this type of trochleoplasty that is done arthroscopically, and maybe you could tell us a little bit more on the history. How did you came to this to develop this kind of technique? And tell us more about it.
Yeah, actually, the story is that I did the open trochleoplasty, and then a patient returned 3 months after the surgery and told me that she had been in so much pain after her surgery, and I had left the hospital, and there was no one there to help her with the pain. And then I thought, maybe we could do this technique by an arthroscopic technique, and it would be less painful. And at that time, I did a lot of teaching on what we call arthroscopy, meaning pinhole surgery in the knee. And we do those training on cadavers. And after the young surgeons has left, I started to do some experiments to see, is it possible to do it arthroscopically? And I realized that it was possible. And then I treated my first patient, and that was back in 2008. And I realized that this type of surgery was less painful. I mean, it's actually not very painful. So that was a huge change. And since then, I've done it by arthroscopic technique. And the history with that is that now these days it has become more and more widespread, and it's actually done, I think now in 16 countries or something like that.
Yeah, I had recently operated on a patient who came to me. Actually, she found information about arthroscopy trochleoplasty because she was exactly almost the same story as you mentioned. She had a open trochleoplasty, which was very successful. The knee was stable, but she had such a bad experience with the pain and discomfort after the surgery that she started to look on possible options how it can be done less painfully, and that's how she found your website. So thank you very much, Lars, for doing this for the patients. So she found your website and she somehow found that I have been trained by you. So she came to my clinic. So she came to Warsaw, and she asked me to have this procedure done arthroscopically. And of course, I did it. It was also successful. So for me, this was also as a surgeon, was a great experience, because usually you recommend for the patient something, and it's not very often that you have a chance to compare two types of procedures done onto both of the knees. But in her case, it was also very interesting story to see the differences that she described. She was also very happy with the stability of the patella, but yeah, she only had four little holes in her knee, and there was the same result, but completely different pathway. So I can confirm that that's true. I also do sometimes open, sometimes I do arthroscopy, trochleoplasty, depending on a different other options. So maybe you could at this moment tell us a little bit more on how we should deal with the complex problems. We have several options like we discussed today. There is a trochleoplasty, there is an MPFL, there is a tibial tuberosity transfer, and there's also a cartilage problem that patients might have. So what's your approach? Would you do everything in one surgery, or would you step those procedures one by one? And what's your approach?
I would say one thing that we haven't really mentioned is the derotational osteotomies, because this is huge surgery compared to the other surgeries. And sometimes I do all the surgeries: derotational osteotomy, tibial tubercle transfer, arthroscopic trochleoplasty, and MPFL in one surgery. And you can do that. And you can even do it as outpatient surgery. And I think you need to do everything in one step. Some surgeons, they think it's going to be too large a surgery for them, but you cannot do things 50%. You need to do the optimal thing, and you need to correct the severe abnormalities in one step.
So what are the risks of having surgery for patella instability?
I mean, naturally there are the traditional risk of infection and nerve injury. Then there is, at least for trochleoplasty, open trochleoplasty, there is a huge risk for what we call arthrofibrosis, meaning too much scar tissue in the joint, so it becomes stiff. And then there are the risks that the patella dislocate again. That, I would say, that's rare. And then there is a very important risk that in most studies that is not included as a risk, but that's pain. I mean, I see a lot of patients who have had MPFL reconstructions, even patients that I have operated myself, who come back with pain. And now their patella is stable, but they still have pain. And often this is due to they have this kissing knee situation and they need to undergo derotational osteotomies to get rid to become well in the knee to avoid the pain.
Mm-hmm. So what can we do for the patients with the complications like this? I mean the arthrofibrosis and persistent pain after surgery. What can be done?
I mean, arthrofibrosis, that has to be dealt with quite early, and you need to do a new arthroscopy and remove the scar tissue. And while the pain situation, then you have to be very careful with your examination and do CT scans and do clinical examination of the knee and a new MRI. As you mentioned, cartilage lesion can be part of it. So there can be many reasons for the pain, and then you have to deal with what is wrong.
Mm-hmm. So what's the percentage of your patients that require a second surgery to treat all these problems?
I think that's very, very rare. As I mentioned, I have had some patient had MPFL reconstruction 4 or 5 years ago, who has returned and had to undergo derotational osteotomies. I think that's maybe 4 or 5 patients. I've had a single patient who got arthrofibrosis, and otherwise, I have seen very, very rare complications.
Mm. So let's maybe look at this from the bigger perspective. Let's look at the patella instability as a bigger picture, right? Because I see many of those patients. The instability of the patella eliminates them from the normal life. Many of such patients have problems to have to do the simple things like going to the park or going to spend an evening with friends and dance in a club, or do so many things that are normal for everyone. Every one of us takes this as a normal thing of our lifestyle. So is treating patella instability, is it just treating dislocations? Is it something else that we should be aware of?
Yeah, because first of all, I would say we have realized that the patients sometimes are much more troubled than we thought they were. Everyone knows, or nearly everyone knows, what a cruciate ligament tear is. And if you're sitting with your family around the table and say you have a cruciate ligament tear, people will understand, oh, this is a serious injury, and if you are playing soccer or handball or whatever you do, people know that this might end up with a surgery. However, if you are having patella dislocation or patella instability, people don't really realize how much this affects quality of life. I often hear patients saying that they don't dare to take public transport. They don't dare to go to a city with cobblestones because then they feel that the kneecap might go out. And yeah, did that answer the question?
Yes, I think so. I mean, it's for me. It was very. I had once this feeling that we have to look at those patients from the different perspective. Like I had once a conversation with one of my patients who had a trochlear dysplasia, so she needed the trochleoplasty, and I was just telling her, the things that we are talking today, like what are the options and everything. So we came up to the moment when we discussed the results, and I was telling her about, when she will be able to return to sports. But she told me, I never did any sports in my life, because she was maybe like, 30 years old. And she had a dislocation when she was in a primary school. So she maybe was 10, 12 years old. And she had this dislocation when she was in school during the classes, and she never did sports. So that's very that explains a lot about what kind of patients we are treating with the patella instability. Many of them never had the chance to do any sports. So for them, it's like many. I guess you have a similar experience, because you've treated much more of those patients than probably than me. So you've heard it more often than I do. But we hear it from the patients. That's a really new life.
Yeah.
They never did sports, and suddenly, especially when you do both knees, and suddenly they can do the things that they can never did.
That's right. I mean, I have all individual variation and stories from patient, and I remember a young guy. He was actually the first patient who had arthroscopic trochleoplasty. He was told by a very famous and skilled surgeon that he would never be able to play soccer again. His knee was so bad developed that he will never be able to play soccer. And then he was operated in both his knee, and he returned to sport. And I still have contact with him, and he tells me that he plays soccer, and that was back in 2008. So that was a great story. And then I have patients who dislocate very rarely, despite they're doing different kind of severe, you can say, what do you call it, contact sports, but it doesn't affect their life, because it takes 1 or 2 days and then their knee is good again. And it happens once a year or twice a year, and they are completely okay. They have no cartilage lesion. And I don't think such patient, where it doesn't affect the quality of life, needs surgery. So every patient has to be listened to and treated individually in respect to their situation.
Mm-hmm. Yeah, I think that this is very important, what you have just said, that we should look at every patient's specific situation. So the treatment should be individual. It should be tailored to the patient's needs and expectations, and of course to the clinical situation. So what happens if I have a patella instability and I decide not to operate my knee? What are the long-term results of having unstable patella?
Yeah, the problem is that for every time the patella dislocate, we know that the cartilage will be somehow, at least in most cases, damaged to some degree, and it only gets worse and worse and worse. And that was what I started saying, that we see these 22-year-old persons coming, having had 5, 6 dislocations since they were 14, 15 years old. And now their knee is in such a bad condition that despite you stabilize them, they continue to have symptoms of pain, and they cannot get to the activity level that they want to, because then the knee gets swollen and painful, and sometimes they need cartilage surgery as well.
So Lars, I think we are coming to the end of our podcast on the patella instability. So maybe at this moment you could please summarize the most important reasons for patella instability.
Yeah, I mean, first of all, trochlear dysplasia, the flat groove. We know that is the most important thing. The next is the high riding patella, the patella alta. And then the other reasons for patellar instability, like the rotational issues, they are more rare, but they are very, very often overlooked. And then there's the thing with the knock knee. It's also called valgus knee. We haven't discussed that. That also predisposed to having patellar instability.
Mm-hmm. So finally, Lars, how can a patient make sure that they are seeing the right specialist for this problem? What are the guidelines? What would you recommend?
Yeah, first of all, they need to do some reading or listen to a podcast like this before they go to the doctor. And then they're going to check out if they have a good examination. And that should include all the things that I mentioned previously with looking at the knee, examine the stability of the patella, both lying supine and in prone position. And then they should have the MRI, and maybe they should ask the surgeon, please explain to me what is going on the MRI, because some surgeons, they only read the description from the radiologist and they don't look at the MRI themselves. And at least that tells me that they don't know what they are dealing with, because you should always, as a surgeon, be able to evaluate the MRI scan. And then maybe you should ask, if they say that you are gonna have surgery, they gonna explain how much experience they have with this particular surgery, and what are the risks and so on. So altogether, this they should feel convinced that this particular surgeon knows what they are dealing with, because many surgeons are only doing these kind of surgeries quite rarely and don't get the experience needed for this, and then they should find another doctor.
I can subscribe to this, Lars. I think that this is critical to understand that the patella instability is not like anterior knee instability. It's not like ACL. It's not like PCL or MCL, which are usually having only one or two reasons. For patella instability, the problem is really complex, and there are so many reasons for patella to dislocate. I think we've discussed all the issues and all the elements of the instability. So I think that it's important that the surgeon can do all the types of the surgery, like an osteotomy, ligament reconstruction, cartilage reconstruction, because there are so many things that can contribute to instability. So, Lars, thank you so much. I really appreciate that you offered your time for me and for the listeners to this podcast. I really appreciate that you shared your great experience. I hope that this is not the last time that we speak together about the patella instability, and maybe we can in future have another recording like this.
Thank you, Konrad. I'm grateful for this. I mean, I love this topic and I love dealing with these patients and the surgeries. So thank you very much.
Thank you very much.
Yeah.
Bye.
Bye.